All right, let's talk about some arthrology. Arthrology is the fancy term for study of joints. We know ology means study of, arth means joints. So what is arthritis? In essence, inflammation of joints, right? Itis means inflammation of. What's a joint? A place where two bones meet, or maybe there's some cartilage or other connective tissue between them. A fancy term for joint is articulation. You have two elbow articulations, your left shoulder articulation. And joints can be classified by structure or function. And this is another key idea in anatomy. Structure has to do with shape, and function has to do with how something works. If we simply say, here are three things, and we can now categorize them as structure, right? But under function, like this one would be for building, the round one could be maybe for moving, and this other one could be for like stacking things together, right? So that's the idea. Anytime we classify something by structure, we're kind of going with shape. And function relates more to what it does. If we look at these structurally, we could have a fibrous joint. Fibrous joints are going to have bones held together by fibers, and those fibers are going to be in some dense connective tissue. These are not going to move a lot, right? If there's a bone and there's a bone, and I put maybe collagen and dense fibers between them, they're not going to move a lot. Another type of joint that will not move a lot is cartilaginous joint. Here's a bone, and there's some cartilage between it. And the ones that move the most are synovial joints. Big idea. Synovial joints move. Those are the ones where we're going to find liquids, synovial fluid, and ligaments that give them support. We could also classify these functionally. And I've also seen it broken down into two categories, but main thing starting on the bottom, we're going to spend a lot of time talking about synovial joints. And basically another name for synovial joints is diarthroses. Anything that moves is probably a diarthrosis. When you're dancing, you're moving your synovial joints. Walking, dancing, moving, typing, texting, all of that involves diarthroses. Saying the exact same thing, moving involves synovial joints. These other twos really either don't move at all, the synarthroses, and those are the ones that are totally immobile, or they slightly move, amphiarthroses. Diarthroses move. The other ones basically don't. We're going to put a lot more into the next video on these, so it's okay. Keep going at this point. Another way to compare joints is ranges of motion. That means how much movement can happen in there. And again, it's the idea that it can vary from absolutely no movement. Hopefully, if you're eating something, there's very little to no movement between your tooth and your gum, right? Very little movement in that joint. But there's going to be a lot of movement in your jaw. You got to open your mouth and do a little side to side, and you got to line up for the chewing. So even in that little bitty area, we can see how some joints have lots of movement, some joints have little movements. And it's really the structure. What's another word for structure? Shape. Shape determines its mobility. Again, go back to my drawings. If I make things shaped like a top, right? We saw that movie. That top can spin around and do lots of movement. Versus if I make things like a square, then it's not going to be able to move as well. So the shape determines how much movement can happen there. And then also there's an inverse relationship, or if I have a lot of mobility, I have very little stability. If I have more movement, I have less stability. And that makes sense, right? It's a trade-off. Your shoulder joints and your hip joints are both very similar. They're both synovial joints. They both have all this movement. But I can do a complete split with my shoulders, right? Because my shoulders are designed to have more movement and less stability. That's why people dislocate their shoulders more. I cannot do a complete split at the hips because the hip joints are designed for more stability and have less mobility. That's why people tend to break their hips and dislocate their shoulders. Both joints are very similar, but they have different structure. Really cool little overview here. I copied this in from the book. It was not in my PowerPoint slide, but that's what we're saying on this part of it over here. We have joints that are more stable. That means they're not going to move that much, like the sutures, where one bone meets the other bone. Technically, and there's therapies that we've talked about that do get involved with sutural movement, but it's very, very minimal. The next one down here is this fibrous joint between the radius and the ulna. So there's some movement there, right? This is not bending the elbow or bending the wrist, but there's some movement between these two bones. If I keep going down, now I'm in her spine. I'm in one of these cartilaginous joints. The bones have a little cartilage between them. So now I have a little bit more movement. But even there, I can keep going until I get down to either the knee or the shoulder. Now I'm getting a lot more movement because now I've reached the two synovial joints in this example. And even in here, we can see how the knee has less movement, but more stability than the shoulder. You know, you can swing your arm in all kind of different directions at the shoulder, but hopefully your knee only moves forward and backwards. If it doesn't, you've got some knee issues. We could break these joints down by fibrous joints. And again, these are the ones that are going to have some connective tissue along with the fibers that are going to connect them. The three types of these, the easiest to remember, the gum phosis. It's in your gums. And it's basically where your tooth meets the gum. And it does have a little bit of a membrane there called periodontal. What's peri mean? P-E-R-I means around, beautiful, boom. Dontal is tooth. But one of the things to catch here is that when you think of a tooth that has like 4 roots, I don't even know how to draw the other two. Whoop, 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 whoop. And let's give it one more, and then you get the other one back there. So this one tooth has 4 gum fauces. There's one, there's the other, and then there would probably be 2, maybe one more on this joint, depending on what kind of tooth it is. Another type of joint connected by connective tissue are sutures. When you're born, maybe it's connective tissue, and then eventually it's going to turn to bone. And we've seen in another video how these really help to lock in one bone compared to the other. After, at some point, they allow growth in the childhood, and at some point, about the age 15 to 21, they start to ossify. Ossify means turn to bone. Here we have, again, we can zoom in a little bit more of that radius and ulna. And here's a perfect example of letting the words help us. Interosseous membrane. Inter means what? Between. Beautiful. Great job. What's os? Bone. Perfect. So literally it's saying here's a bone, here's a bone. This is the membrane between them. And the beautiful thing about this is it helps forces. So that like if something impacts you on just one side of your hand, all the force doesn't go just into one bone. This kind of spreads out the force between the radius and the ulna in this picture. And then there's also one between the tibia and the fibula. You're familiar with these if you ever go to a restaurant. Boom. I love this. So proud of myself. I'm such a nerd. I was fishing and I made this meme. So if somebody orders 12 radius and ulnas, you can get a dozen chicken wings. That's exactly what, you know how chicken wings, some of them have 2 bones in them? Yeah, those 2 bones are the radius and ulna of a chicken. And I'm telling you, if you look at them, you could even figure out which is which, because you're eating a chicken antebrachium. If you're eating a chicken leg, you're probably holding what? The chicken leg is probably the tibia. The thigh would be the femur. Depends on how it's cut. Okay, keep going. Another type of joint is when we have hyaline cartilage connecting 2 bones. This was the easier to see where the ribs come in and attach to the sternum. Have lots of cartilage in here. And think about every time you breathe, those ribs have to move out and up a little bit. And every time, especially if you forcefully exhale, like blowing out candles, gosh, are we ever going to do that after COVID? Those ribs move in again. This is also kind of neat that this is part of the protective thing that helps someone if they have to have CPR applied to them. It's not directly compressing the bones. There's a little bit of this cartilage between there. I'll come back to this, but sometimes this cartilage where the ribs meet can get inflamed. Again, we know itis, we'll break it all the way down. Cost relates to ribs, like costal. Cond relates to cartilage. And itis is inflammation of. And sometimes this can be a trauma, like maybe someone's in a car crash and they have not wearing a seatbelt and their chest gets compressed, or maybe just a really nasty fall from skateboarding or something else where they're literally have a chest impact. Sometimes, unfortunately, it just happens, or even could be a post-infection. I skipped one picture, so I'm going to go back. This other example here, this would be a growing bone. What we're looking at here is synchondroses, and again, synchondroses have that hyaline cartilage. Here's the most normal example. But in this situation, this is still a child, and there's still lots of cartilage in here, and so this bone is growing. And so technically the part between here and here would be a synchondrosis, 2 bones, technically 2 separate bones connected by hyaline cartilage. And then the last type of overview of a joint is a symphysis, and a symphysis are where things join together. Sometimes pop songs, right? You'll get two or three different artists together, and they'll create a symphony where they put things together. And these do have some mobility. The easiest to think about would be in between the bones. And I'm just going to make up, I'm not sure. Let's call this L3. What's that mean? Yeah, perfect. That would be the third lumbar vertebrae. What would be underneath this drawing then? Yeah, the sacrum. If I went up 3 layers, where would I be? Did you get T12? L2, L1, T12. All right, but anyway, in this drawing here is a symphysis between L3 and L4, specifically called the intervertebral joint. Here is the L4, L5 intervertebral joint. Here is called the pubic symphysis, where the left pubic bone and the right pubic bone meet. Your pubic symphysis is kind of right behind your zipper. That's the first video. Let's keep going in throughout the chapter. Let's talk a little bit more about these synovial joints that are inside our body. We know that most of the joints in the body are actually synovial joints, and another term is diarthroses. I just want to tell you there's so much repeat in this little bit of section that it may be good just to listen, and then we're going to get these notes when we see it a little bit more in detail. But what do we know? We know synovial joints are the most common joints in our body. We know another term for synovial joints is diarthroses. Synovial joints are where we're going to find synovial fluid and articular cartilage. We'll see slides with all of this. These joints have blood supply, so there's an artery taking blood in, a vein taking blood away. There's nerves, so that if you twist or tweak these joints, you're going to know it hurts. And there's ligaments in these joints. But most importantly, synovial joints are famous, or their key distinction is there's always an articular capsule, something wrapping around the joint, and a cavity, a joint cavity inside the joint. When we look at that capsule, we're going to see when we get to the pictures that there's actually 2 layers. The outer layer is this dense connective tissue, very, very tough. It's going to cross from one bone to another, acting like a ligament, and actually keeps the bones from being separated. Versus inside is that inner synovial membrane, and that's the one that has much more tender areolar connective tissue, and that's the one that actually makes the synovial fluid. Other structures, articular cartilage. Specifically, think hyaline cartilage. That's always going to be on the part of the bone where the movement happens, on the joint surface. And articular cartilage helps reduce friction, helps things move and kind of slide past one another. It also can act a little bit like a cushion to absorb compression. Like if you jump off the top of a box so that the lower bone, the tibia, doesn't just crash into the thigh bone, the femur. You have little structures, little pads in there. So the articular cartilage would give you some protection. This word perichondrium means the articular cartilage doesn't have some extra connective tissue around it the way other connective tissues do. But one of the things about articular cartilage is it's avascular. It does not have a blood supply. The downside of that is damages are going to take a long time to heal. The space inside these synovial joints can be called the joint cavity, but it's not an empty space or a space with gases. It's actually a space with fluids, and that fluid is called synovial fluid. And again, synovial fluid can kind of act like a shock absorber to help us keep everything padded. It also gives us a little oily or viscous substance so that things kind of slide past one another. Synovial fluid does not nourish as well as the way, say, maybe blood is going to take true nutrients to most cells, but especially it helps the cartilage to get rid of waste. Technology, don't fail me now. I'm going to try. So starting with that articular capsule, all of this would be that outer portion. Notice how it literally wraps all the way from one bone to another. And inside of there would be the actual synovial membrane. And if I was going to trace it, I would realize that this is synovial membrane. Even what we're kind of seeing back here would be some deep synovial membrane. On the ends of each bone would be that articular cartilage. Remember, articular cartilage is usually hyaline cartilage. The cavity, where it says joint cavity, remember that's a space. And so I'm going to do this little highlighter where the synovial fluid is. So that synovial fluid, it's made by this synovial membrane. So all of this would be where the synovial fluid would be. It would just be kind of a little air, a little cushion of fluid to help keep this bone separated from this bone. And that synovial fluid would wash over this articular cartilage here. And then I'll just switch to the outside. The ligaments would even go further. Now we're even more superficial than that top part of the joint capsule. And so remember, ligaments, which is going to connect bone to bone, if I put it here, it would be more superficial than the external part of that articular capsule. Ligaments themselves are typically dense, regular connective tissue. They all tend to be going in one direction here, and ligaments connect one bone to another. Two good terms to know. We've seen these in cells, but there are lots of things, right? If I'm X anything, I'm outside. So here, trinsic would be the joint. Extrinsic, I'm separate. I'm outside the joint capsule. That would be the one I was describing on the previous page. It goes all the way through there. But intrinsic is inside. If we think about your knee, let's give them some bones. Down here is the tibia. And what's the thigh bone? Yeah, the femur. And those two bones have ligaments that cross. Those would be the intrinsic ligament, the anterior and posterior cruciate ligaments. On the outside of the knee would be a medial and a lateral collateral ligament, and those would be the extrinsic ligaments of the knee. Does that make sense? Intrinsic is inside that capsule. Extrinsic is outside. We mentioned how synovial joints also have sensory. That's great because your body needs to know what's going on, what kind of movement. Are you stretching? Are you speeding up? Are you accelerating or decelerating? But with sensory nerves comes pain, or at least the potential of pain. And so that's why, like swelling inside your hand is not as painful as swelling inside your elbow. And that's because your elbow is a synovial joint and it has different types of nerve detectors. And then tendons, remember tendons is what connects a muscle to bone. And those also can help stabilize the joint, but it's not actually part of that synovial membrane or synovial joint structure. Another structure, bursa, is a little sac. And it's a little sac that has some fluid inside there. That fluid would be synovial fluid. And the best way to understand bursa, if I was going to go rappelling down the side of this cliff, and I had my little tree up here I was going to tie my rope to, if I just took my rope and tied it around the tree, what's going to happen right there? Yeah, it's going to probably not even get me halfway down the mountain till it frays. And so a bursa is literally a little sac. It's a little pouch. It's not part of the joint. It's just protecting it. So that now that rope maybe could go over that padding and it's going to have a lot more protection. So what does a bursa look like in the real body? Well, your knee, actually each knee has several bursa. And look how the names help us here. We know that patella means kneecap. And so if I go anterior or in front of that, I'm at the prepatellar bursa. If I go above there, I'm at the superior to, suprapatellar bursa. And if I'm beneath there, infrapatellar bursa. But each of these are places where we get a lot of friction, right? Think about every time you bend the knee. And then specifically, this prepatellar bursa is often irritated, like say somebody is installing tile and they spend an afternoon on the knee, and then the next day this thing is just super inflamed, bursitis. A couple of other structures besides bursa being the little sac. If I have a really long tendon, that bursa will kind of flatten out and protect the tendon all the way around it. And so that's real common to happen in the wrist and the ankle on both sides. And then we also have little fat pads. And that fat pad, again, it's kind of right near the joint, and it's just going to give it a little bit more protection and kind of fill up the spaces. So let's take a look at what I'm talking about. Here's this long tendon going all the way from digit number what? Yeah, good job, digit number 4. And I need to be able to move digit 4 without moving digit 3 and digit 5. And so they have these little, like I say, it's like a bursa, but it's stretched out, so it's called a sheath. Just like if you ever watched Game of Thrones, right? They had the long sword and they drew it out of the sheath. But when the sword was in the sheath, you couldn't see any of the sword. It was fully protected. And so the same thing here, you really can't see the tendon because it has this nice sheath. It's especially easier to figure out here how we can keep all of these separate so that hopefully I have the ability to move one finger without all the other fingers being involved. Finally, we're going to break these joints down a couple of different ways. We remember that we have different planes. And if I'm a plane, we remember there was a sagittal plane, which divided me into what? Yeah, beautiful, left and right. A coronal plane that divided me into what? Anterior and posterior. What's the other? Good, transverse or horizontal plane, which divides me into superior and inferior. Each of these planes also have specific types of movements that go with it. And for now, just memorize it. It'll make sense. But if I'm in the sagittal plane, I can do flexion and extension, and hyperflexion and hyperextension. If I'm in the coronal plane, I can do lateral flexion, and I can do abduction and adduction. And if I'm in the transverse plane, I can do rotation. So if I understand this, many joints move through just one plane. Whether that one plane is the sagittal plane, coronal, or transverse plane, many joints in our body are uniaxial. That means they can move through one plane or kind of move in one direction. Other joints are biaxial. Maybe they can move through these two planes and not the other. And then the most movable joints are multi-axial. They can move through any direction. So here's a list of synovial joints going from the least mobile to the most mobile. And I'll tell you that I would not be able to put these in exact disorder, but if we go through the types of joints, hopefully it's going to make things make sense. If I'm a plane joint, here's one bone, here's another bone, and these two flat surfaces are going to try to move past each other. And so plane is uniaxial. All I can do is slide. And these are very immobile. They're the least mobile. The other type would be like a hinge. A hinge is also uniaxial. If you think about it, a door can just swing open or swing closed if it stays on the hinges, right? It can't twist or rotate. All it can do is move in one line, in one plane. But it can move a little further than a plane joint. The pivot joint, now we're uniaxial, but that axis would be like rotation. Think about that movie where they're spinning the top. You know, I don't want to ruin it for you if you haven't seen it. It's okay. But on here it pivots, and so it has even more motion. If we start getting into multiple planes, biaxial, now I have a condyle, like maybe the shape of the knee. and where I could actually slide kind of forward and back on this part and kind of forward this way and there that way. So two different directions. And the same shape only pointed in a different direction would become the saddle type of synovial joint. The most mobile joint are the ball and socket. These are the most mobile and they're multi-axial. With ball and socket, I can do everything. I can flex and extend. I can internally and externally rotate. What else can I do? Missing. Oh, AB and AD duct. I'm thinking about my shoulder. I can flex and extend my shoulder, bringing my arm forward and backwards. I can internally and externally rotate my arm, and I can AB and AD duct at my shoulder like I'm doing a jumping jack. Nice little comparison of the three types here. A plane with one flat area sliding past in one direction. Here it's a hinge, still just making one area of movement. If we get a little fancier, here I'm pivoting, like shaking my head no, and this bone literally pivots on the other. But then we get to the shoulder and the elbow, the true synovial joints, where I have lots of range of motion. Last thing, we use these terms a lot. If I'm a concave surface, I've caved in. And if I'm a convex surface, I'm curving upward. And we can do it, it doesn't matter if it's upside down. What type of surface is this? Good, that's the convex one. And the one on the bottom is the concave. So whenever time we're using this, the convex surface is always kind of an outward curve. And a concave surface is always kind of caved in, an inward curve. What's up, gang? I kind of figure since this section's about movement, at least I'd be on the screen so that you could see some of the movements I'm doing. First, let's get the notes out of the way. We remember gliding movement. That's when one bone is usually square and it's going to either slide past or slide up in one direction. So there's not a lot of movement that goes on between gliding. And that's usually located in our wrist, where the carpals are, or down by our ankle, the tarsals. In addition to gliding motion, most movement is considered angular motion. If we think about my upper arm and lower arm, just to oversimplify, if that's my upper arm and that's my forearm, if I bring my arm toward my shoulder, then I've decreased an angle in there. Or if I took my arm and straightened it out, now I've increased an angle in there. And we'll get into some specifics. But I would know that all of these are types of angular motion. The first one, flexion. And it's kind of easier if we put them together. Both of these happen in an anterior and posterior movement. So we could say both of these happen along that sagittal plane, right? Sagittal plane, so I go forward and back. The definition of flexion is we've decreased an angle between bones, and the definition of extension is we've increased angle between bones. But it makes sense. Most things in the front flex forward. If I flex my neck, my head goes forward. If I flex my spine, my trunk goes forward. If I flex my shoulder, my arm goes forward. If I flex my elbow, my forearm goes forward. Flex my wrist, my hand goes forward. So an easy way to think about it is above the waist, flex forward, extend backwards. The definitions, though, actually relate to the angles. And so if I go back to my neck, flexion is going forward, extension is coming back to where I started. And if I continue to go back, then I'm actually doing hyperextension. And so hyperextension can be thought of anything beyond anatomical position. From the shoulder, here I've flexed, here I've extended, and like if I reach behind me, I'm hyperextending my shoulder. And then another term here is lateral flexion. Lateral flexion is the idea of maybe taking my ear and taking it toward the same shoulder. Here I'm doing right lateral flexion. Or I could take my entire spine like I'm a teapot. Right lateral flexion. I know I'm doing a great job, but just to put the pictures and the movements in here, this person starts in anatomical position. If you're in anatomical position and I say, show me extension, don't move. And I'm going to say, great job. Now, if I say, show me flexion, now show me extension, you got to come back to here. If I keep going, I'm in hyperextension. The same thing as the arm goes forward. The forearm comes forward in flexion and backwards in extension. And here we can see how, if I just look at the elbow, so here is one angle, and after they flex forward, that angle is reduced to here. So that's why we mean if the angle is getting smaller, we've probably done flexion. And if the angle is getting bigger, we're doing extension or maybe hyperextension. Even in this same drawing here, this wrist is what? Yeah, it's a little bit flexed. Kind of makes sense. It's doing some wrist flexion. And if it went the other way, it would be wrist hyperextension. I dislike this drawing because they're out of anatomical position. So I'm going to go with anatomical first. But wrist flexion, wrist extension, and wrist hyperextension. They're doing the same thing, but they're in a weird palm down. We haven't got to it yet, but they're doing pronation. And so now it's weird, but this is wrist flexion. But if I rotate my arm, I'm still in wrist flexion. And even if I bend my elbow, I'm still in wrist flexion. So it's the idea, we're learning these one at a time, but in reality, we probably move the entire body, or at least the dynamic portion of the body. The last one here is where I was talking about our knees and our ankles are weird. Everything else flexes forward, but when you flex your knee, your foot goes behind you. And here's an example of kind of full trunk lateral flexion. To get some terms in, I'm gonna pronounce them as abduction versus adduction. I say that just to help you. I've heard them as abduction and adduction, and then you sit there and like, what did he say? So I usually try to pronounce or remember to pronounce the second letter. But if I'm abducting, something is going away from, right? I've been abducted. Here I'm abducting my shoulder. It's going away from the midline. If you're being abducted, somebody's taking you away. Versus if you're doing adduction, it's going toward you. If I come toward you and give you $5, I added to you, okay? So adduction, going toward the midline, abduction, going away. Spelling the words, a deduction versus a abduction. So here would be a B and a deduction. Notice that she's out of anatomical position though a little bit. Here we have a good view of wrist, a deduction. This wrist would go along here on this side of the body. So they're a deducting their hand or a abducting their hand. I've also heard this called radial deviation and that called ulnar deviation. Just kind of letting you know. But even the same thing, if I'm going away from the body, like doing a split, right, like someone else doing a split, a abduction. And if I'm squeezing my legs together, a deduction. A neat thing about the hand, digit 3 is considered the midline. And so if all the fingers are going apart, it's digit abduction. Kind of covered over the last word there. Digit abduction. And if all the digits are coming in toward that midline, then you're doing some digit adduction. Our next one is circumduction. And to easily remember, think about circumduction as making a circle. But in reality, when you do a circle with your hand or a circle with your foot, the limb kind of does a cone shape movement. So sometimes this is described as imaginary cone circumduction or cone circumduction. But again, it's because it's a long chain, right? And in order to move my hand a lot, the shoulder only has to move a little bit. But most types of rotation is pure rotation. And with that, I could go lateral rotation, going away from me, or medial rotation, bringing things in toward me. And it makes sense that I could do my entire arm. I could laterally rotate my arm or medially rotate my arm. And if we do it in the forearm, then it has specific words. These are only used in the forearm. But if I'm going to skip one. If I'm doing supination, think about it this way. I'm scooping soup. Supination is like the palms going anterior versus pronation is pouring it out. So if I'm doing pronation, my palms end up going posterior. And again, this would be down by the side. I'm just bringing my arms up so I could so you could see. So here in this picture, on the far side, we're just doing pure left and right rotation. But then we get into the limbs. And it's a little easier to see with the elbow bent. We could also have the patient keep their arm straight. But with the elbow bent, it's easier to see how this right arm is kind of doing lateral rotation. I'm seeing the medial part of the arm here. And now they're doing medial rotation. I'm seeing the lateral part of the arm. Same thing in the leg. If this leg does lateral rotation, I would see more of the medial thigh. And it's kind of weird, but if they do medial rotation, typically we're going to see more anterior. You're probably not going to have enough medial rotation in here to get all the way there. But we can kind of see it. It's pronation, so they've poured it out. Supination, so they're able to carry soup. 3 more special movements. The easiest to understand is the scapula. I can elevate, going superiorly, or I can depress, going down. You can also do it with the mandible. Depression and elevation. A beautiful way of telling someone to shut up. Please elevate your mandible. Good stuff. Here we see scapular depression and scapular elevation. Notice that if we elevate first, we could depress a lot more. If we only are in anatomical position, you've only got about 10 degrees of depression. 2 other movements, the ankle gets really weird. It used to be called flexion and extension, but now just think about if my toes go down toward the planet, I'm doing plantar flexion. Otherwise, I pick them up and I'm doing dorsiflexion. Imagine trying to walk on your heels. Your toes are off the ground. You're in dorsiflexion. Michael Jackson, when he would do those awesome dance moves up on his toes, his feet were in plantar flexion. These are relatively easy to remember. If my foot escapes, then I'm in eversion. If my foot goes inward, I'm in inversion. The jaw and the scapula can protract and retract. There's a guy on Family Guy. And they always draw him with a big overbite, with a very protracted mandible. But he also can do it with our scapulas. I can protract my scapula when I give a hug, especially if I'm not looking up and my scapulas go out this way. And I can retract my scapulas, squeezing them back together. Retract, protract. Same thing in the picture we're seeing there. My favorite thing that I've ever heard a student tell me, my moment. We do not have disposable thumbs. We have opposable. So opposition means that my thumb and another digit can touch something, like to squeeze something. Here we're seeing thumb and digit 5, but think about the way you maybe use a key and oppose digit number 2 and digit number 1 and 2 to put a key into a lock, or maybe you swipe a credit card. And then going back to where it started is repositioning. All right, levers are very complex. I used to give a 1 to 2 hour lecture specifically on levers. I'm going to try to do this complete video in 10 minutes. If we think about the most basic lever people are familiar with, a seesaw or a teeter-totter, right? One side goes up, one side goes down, and there's a pivot point in between. That pivot point is the fulcrum. And either side, we could technically name either way here, but I'm just going to call one side effort and the other side resistance. Or the next part of a lever, all of this is considered the lever arm, like the bench, right? The bar. All of this is considered a lever arm. And we can divide that lever arm depending on whether it's connected to resistance or effort. And so in this example, everything from here to here is the resistance arm. Everything between where the resistance and the fulcrum meet. And then everything between here to here would be the effort arm. One big idea is if I move things, I change things, right? If this is a teeter-totter or a seesaw and we put two even weights on it, it would stay balanced if I drew my fulcrum exactly in the middle. But let's say we still have even weights and I bring my fulcrum really close to one side. It's still the same thing. I got resistance on one side, effort here, only now the effort arm would be this big and the resistance arm would be that big. The resistance arm is always the distance between the fulcrum and the resistance. The effort arm is always the distance between the effort and the fulcrum. The only tricky thing to add is all levers have these let's pretend I drew a straight line. All levers have these three things, but what we're going to see is the only thing that changes is the order. The fulcrum will be at an end, and then the two forces are in order. Sometimes these forces are the resistance and then effort. Sometimes it goes, this is the effort and that's the resistance. The way I just drew it, if this is the effort arm would be here to here. The resistance arm would be here to here. It's always the distance between the resistance and the fulcrum, or the distance between the effort and the fulcrum. Levers are laid out in three ways. The first one I drew, I think of as a seesaw. In your book, they call them a pair of scissors, because if you think about, in order to make this part of the scissors go down, I have to make that part of the scissors go up. So it's still a seesaw or a teeter-totter. The fulcrum is between the effort and resistance. Just like I drew, the fulcrum is between the effort and resistance. The one thing I would add is the effort and resistance move in different directions, right? If one side of this teeter-totter goes up, the other side goes down. An example in the body is basically your skull, your occiput on your top vertebrae. If you think about it, if your chin goes down, your head goes up. If your head goes up, your chin goes down. First class lever, fulcrum in between. A second class lever, and these are kind of rare in the body, there's not a lot of these, but now what's happening is we have a fulcrum on one end and the resistance is between the fulcrum and the effort. The other key thing is both of these are now going in the same direction. The classic example is a wheelbarrow. The fulcrum is on one end, the resistance or whatever I want to lift goes in the middle, and I grab the other end, the effort, and it goes up. Still, we have a resistance bar between the fulcrum and resistance, and an effort arm, the entire bar basically, between the fulcrum and the effort. One of the benefits of this is it allows more work to be done. But there's not many of these, and so an example is plantar flexion. Let's use a fancy word, right? Plantar flexion. Stand on the ball of my toes, gravity is trying to pull me down. but my gastroc, my heel muscles raise me up. These are rare. Most muscles in our body work like a third-class lever. And now with a third-class lever, the effort is kind of in between. The effort is between the resistance and the fulcrum. And an example could be forceps or even a stapler, right? Most people are not going to push exactly there on the staple. You grab it there and push down. So the effort goes there, and then the resistance goes down after it. Another example, whether these are tweezers or whether they're ice trays, but you're going to squeeze the middle part here, and that makes this end go up. Most voluntary muscles in our body work this way. If I over exaggerate and I just make the forearm one lever arm, here's the fulcrum at the elbow. The bicep brachii is grabbing and pulling there, but whatever I'm holding in my hand is pulling in the other way, other direction. So I have to fight against it.
So if we look at 3 types of levers, we could go 1, 2, 3. FRE, the thing that's in between. And what does that look like? In a type 1, the fulcrum is in between the effort and the resistance. And the other thing about a type 1 is they're going in different directions. In a type 2, we've got our fulcrum on one end. The thing that's in between is the resistance, and they're both going in the same direction. A type 3, the thing that's going in between is the effort. The other end is the resistance. Type 1, type 2, type 3, the thing in between. Type 1, F, the fulcrum is between the resistance and effort. Type 2, the resistance is between the fulcrum and effort. Type 3, the effort is between the fulcrum and resistance. 1, 2, 3, FRE.